So I see a lot of second opinions with regards to that, both from the region around Massachusetts, but also other parts of the country. Our center in general, and I brought some information about our center. You can imagine being one of the larger hospitals in the country. We do everything there. It's a very comprehensive evaluation. We do things such as, medication treatment, diet therapies, surgical therapies if we need to get to that point. And it's a luxury because we have, experts in every single field. Genetic epilepsy experts, doctors that just focus on surgery in and of itself. So a lot of different, specialists that are present at our center. This is just some information about all that. And our contact information as well if you should ever need to get in touch with us. And I'm not going to spend a lot of time talking just because this is really an opportunity for you to ask me as many questions as you have, and I'll do my best to answer them. And if I don't know the answers, I can point you in the right direction. But I do like to start by going through just one thing, because I think it's important for families to know exactly what doctors are thinking. When you come to us in the setting of having had a concern that your child may have had a seizure. So I kind of had this, and I actually presented this last year, but it's just one slide, but it kind of goes through the thought process, and I think, again, that's kind of important. I don't know if you guys can all see this. Can everyone kind of see this? All right, good. So again, the first question that comes up is, was the event in question actually a seizure? Because you can imagine there's actually a lot of mimics, a lot of different things that look exactly like a seizure that may not be a seizure. So you can imagine you don't want to move down the path of a question of epilepsy if the event itself is not a seizure. So the first test that we typically do, and I'm sure you guys are familiar with this, but if you're not, just tell me and I can talk more about it. As we try to figure out what type of seizure it was, we think to ourselves, well, was it a generalized seizure, meaning was the seizure abnormality coming from both sides of the brain at the same time, or was it more of a focal seizure in which the abnormality may have come from one side of the brain and then possibly quickly spread to both sides? The first test that we oftentimes do is an MRI. So we look for some brain abnormality as the reason for why a child may have had a seizure. If that's negative, we start thinking about other things like genetic causes. And I think that there's a common misconception. Parents oftentimes think that a genetic cause means that it was inherited from mom or dad. And that's actually not the case. It's actually very rare for kids to have had a genetic epilepsy that is inherited from mom or dad. And there's some, that varies a bit. If there's clearly a family history of other family members having had the specific disorder, then it is carried through. But the other thing which really kind of racks our brain is that oftentimes the cause is unknown, and that's frustrating for parents but also for doctors. But unfortunately, that's the challenge with seizures and epilepsy. And then at that point, we start thinking about things like treatment. The first thing we always try to do is treat the seizures with medication. However, when medications don't work, we think about other things like diet therapy, like the ketogenic diet. I'm not sure if any of you have experience with that. And then finally, when those things fail, that's when we start thinking about things like surgery. So again, I just showed this to you to give you a sense of what we're thinking as we're evaluating kids that come to us with a possible seizure. So like I said, I wasn't planning on doing a lot of talking, so at this point I'll sort of hand it over to all of you, and if, like I said, answer any questions I can.
How reliable is that in the diagnosis of if it's looking for a cortical dysplasia versus like a low-grade glioma?
That's a great question. I find it not to be reliable, to be honest with you. I tend to use spectroscopy in settings in which I'm worried about a metabolic cause. So sometimes kids have seizures secondary to some issue with their breaking down certain things like proteins, fats. Some kids in rare cases come to us because they have a mitochondrial disorder, and I tend to use spectroscopy more in that sort of domain. If there's clearly a cortical dysplasia and there's a question of, well, is it a low-grade glioma versus a dysplasia, it could be a little bit helpful, but frankly, for me, I use it more for the question of, could this be some underlying metabolic cause? sure if that answers your question, but that's my take on spectroscopy. Yeah.
If a patient is given Ativan, say, within 6 hours of getting an EEG, do you think that the reading of the EEG would be accurate because of the medication, or would it give all the information that it could have?
Yes, that's a great question. And the answer to that is yes. Ativan, one single dose of Ativan, or even a couple of doses of Ativan, shouldn't necessarily distort EEG with regards to us being able to know if it suggests a risk of seizure. Now, Ativan can make the background brain waves a little bit slower than you might expect, but that's all right because we don't worry that much about the background brain waves in a setting in which a child has gotten a medication. Now, the question of does the EEG, can there be some change in the EEG with a kid that's on medication? The answer is yes. There are a lot of good medications that actually suppress spikes on the EEG.
What we're asking is something a little bit different. With the light of hope, depending on the website that you can go to, you can get this information. What we're asking is how can we get the people to come and say the things that we need to say about the care of people with epilepsy. So somebody who has the authority to make the changes can make those changes.
I think that once you start getting people out there, I think that once the word starts getting out, that you start telling the stories, and especially with Facebook, they start tagging other people that they know. They see something pop up in their feed, and they go, oh, that sounds like so-and-so, and they tag them. And I think that that's one of those things that if you have I don't want to say a good story to tell, if you have a story to tell, your story is going to touch someone else at some point or another. And I think that those types of stories tend to kind of snowball into other things.
Do you think if you go to Congress and you tell your story, you will be able to have as much as an effect if you have more stories put together that they have a common thread?
If I go to Congress, did you say?
Yes. See, what we are asking you guys, to do is to help us out change governmental policy. You're talking about changing doctors.
No, I'm not talking about changing doctors.
Changing some of the approaches.
The information that doctors give, not the approach that a doctor makes in a care. It's different than what I'm saying.
You're talking policy and Congress and how do we increase funding for research and how do we make an impact?
Actually,
on the
there's something different.
course.
Funding for care.
Right.
Not necessarily for research. Yes, we will have the research, but we care about care. The issues that people with epilepsy face are across the pendulum. Some have more needs, some have lesser needs, but they don't get the attention that they need because people are hiding. They're hiding.
Well, one of the things that you were talking about was creating this community.
Yeah, there's a lot of scared people out there that have absolutely no idea. Like we said earlier, before anybody else came, we said people don't. And I said that the thing with epilepsy is that what I think is lacking is that so much of the majority of the public, they hear epilepsy and maybe the only thing they think of is seizures. That's it. And maybe they take a medication and they don't have their seizures anymore. And as far as their knowledge for that, it ends right there, right? They don't realize the daily struggles that someone has to go through that has epilepsy and all that goes into the caregiver or the person themselves taking care of themselves, trying to be independent. And I think that that's something that definitely it needs to be more widely known.
But in many ways we're talking about two different things. One is, you're absolutely right, people need information, they can get it from one another. But the problem with that, it's very helpful to those people, but it stays within that community. And one of the things that we think needs to happen is that the system has to change so that all the problems that you encountered, the orientation the doc has in the office about just doing the seizure counts, it gets expanded to something a bit bigger. And that the system is changed so that people with difficult to control epilepsy get to see someone a lot sooner in the course of their disease and illness than they do now. Because we see all the time that people, and this is not necessarily, you can be in the hinterlands in Chicago, okay, but that are in the medical hinterlands, and they never get to a place where people understand the issues for epilepsy. And that's a systemic issue. You can talk with one another about, go see Dr. X, he really helped me, and that's a very good recommendation to make. But that's a one-on-one situation where we have 800,000 people in the U.S. with intractable epilepsy, maybe a few more. So, and most of them are never getting to see an epilepsy specialist, anybody who knows anything about epilepsy. And so one of the questions we have is taking all the issues that you're dealing with, but how do we then convert that into a change in the system? Because that's what really needs to happen. And the docs really can't do this. We're always a suspect, probably with good reason. We're always suspect when we go talking about things. But it's something that the patients have to do. And so how can you take your experiences and use those to get the system to change? And that's really kind of one of the big things, because the reality is people with epilepsy don't like to talk about it, other than on Facebook, and they just don't want to talk about it because it's got lots of baggage that's inappropriate. But so how do you then take this and say, look, and when Nico said, take your story to Congress, that's exactly the issue, sort of all the problems that patients have had with their epilepsy, and it gets lost. They talk one another, but it gets lost, and so people don't get it to where it needs to go, which is to the people who can actually change the system. And that's kind of what we really think needs to happen, is that the system needs to change. I mean, Pete Engel at UCLA has gone for years about, even though epilepsy surgery for a lot of people is the treatment of choice, that it takes sometimes 20 years from the time somebody was diagnosed, even though they're clearly having intractable, before they actually get to a place where they could have had it done 15 years before. And their lives would have been, they had 15 more years more normal life. And so those are kinds of the things that, how do we affect that kind of change so that people with difficult to control epilepsy get the care they need and have all the issues addressed that we're concerned about.
I'd love to be part of that. And we've done it at the state level, not with the greatest success in Illinois, because Illinois has a lot of other issues that they're dealing with, right, with budget, and unfortunately it's those who are the most vulnerable, those who don't have a voice for themselves, are the ones that get the money pulled out first and have the rug literally pulled out from underneath them and don't have anywhere else to go. And I think sometimes you need to put the face with the problem, because when it's just a problem, it's easy for them just to swat away that fly. And I think that when you start putting faces, it's a little bit more difficult for them to swat.
When the psychological component comes into it, we know that patients with epilepsy have different ways of processing their emotions than someone who does not have epilepsy. And I think it's important to understand that if the psychological factors are affecting their diet, the use of alcohol, their ability to take their medications, there are certainly aspects that not necessarily are directly related to the stress of it, but that can affect their overall well-being and health. So the answer to your question in multiple parts is yes, the psychological factor is an important factor, but it's not the whole picture.
Okay, thank you.
Yeah.
At what point at what age is it considered adult onset epilepsy? I came down with epilepsy at 18, so is that considered adult onset, or is that because he didn't want to?
It's a gray zone.
Yeah, he didn't want to. He at first he said juvenile myoclonic epilepsy, but he took that back, and now he said it's partial epilepsy with secondary generalization.
Yeah. So, developing seizures at age 18 can be tricky because there are a number of syndromes that can develop earlier. You mentioned juvenile myoclonic epilepsy as one, where we have teenagers or young children as early as 12 or 13 that can, or that start developing their epilepsy much later in life, like in their 20s. I think in general, if you do have juvenile myoclonic epilepsy, it still kind of falls into that juvenile category. Developing seizures at age 18 can be considered, either pediatric or adult, depending on the seizure types and depending on what is the cause of your epilepsy. When I'm sitting down here and kind of discussing adult onset epilepsy, I'm really thinking about patients who develop epilepsy after living a seizure-free life with no neurological insults, and then at some point in their life they develop head trauma, or they have a stroke, or they have an infection that then over time increases their risk for epilepsy and then develops into an epilepsy after recurrent seizures from the same area. Yeah. So I guess the short answer to your question is, without knowing you and your medical history, it's really hard for me to say, are you an adult onset or are you not? But I mean, I think either way, the therapeutic goals have to be aimed at ensuring that your seizures are appropriately treated with the right medication for your type of seizure and epilepsy to reduce your risk of having ongoing seizures. Yeah, absolutely. I'm sure you guys have a question, or are you just listening in?
So I'm on a huge cocktail of AEDs, and I feel like it's affecting my memory significantly. I feel like I'm not as sharp as I was. It's very hard to pay attention, and the quality of life and my ability to do my work is suffering. So what would you suggest? Because I went to some neurologists want to go the surgical or device route right away, and some just want to keep tinkering with the medications.
The question is really related to the use of medications and what we call polypharmacy, or the use of multiple medications, and the side effects and how that will affect your quality of life and the treatment of your epilepsy. The International League Against Epilepsy has said that if you have taken 2 medications at a therapeutic dose and you continue to have seizures, you technically fall into a category of refractory epilepsy. Refractory meaning probably not going to achieve seizure freedom with medication alone. And that's based on data from 2 doctors, Kwan and Brody, that has been looked at and re-examined over the last 15 years. And it basically shows that once you kind of have tried and failed 2 medications, you really don't have a high probability of adding a 3rd medication and achieving any better control, or a 4th medication or achieving any better control. So we know that the most common side effects of all seizure medications, or anything that actually really works on the brain, are sedation, sleepiness, right? Thought disturbances, balance problems. The more of these, what's that? Weight gain can be a side effect of some medications, and we also know that there are a couple of anti-seizure medications that also, in and of themselves, can cause cognitive problems, like topiramate or zonisamide are both associated with cognitive issues. That's why topiramate, it came out as Topamax, and now it has the nickname on the internet, Dopamax. But the point is that any cocktail, once you get past that one medication, we know that the side effects can start adding up, and adding up very quickly. Now, in terms of the second part of your question, which is, when do you really start thinking about surgery? You mentioned some neurologists discuss surgery really early on, and some say, well, let's play with the medications a little bit and try to find the right combination. In a patient who has a known specific seizure focus, and we can say confidently all the seizures are coming from one place, and if that patient has already failed a couple of different medications or multiple medications medications and still continues to have seizures coming from that one place, or has such bad side effects from the medication, then considering surgery is reasonable. Now, the commitment to consider surgery, though, is a big deal. What's involved with a surgical workup? Well, generally, you're going to see an epileptologist at an academic center. They're going to probably want to bring you into an epilepsy monitoring unit where you're going to be committed to staying there for 5, 6, or 7 days and getting a video EEG with your medications reduced. The reason is they want to generate those abnormal rhythms in the brain. They want to generate a seizure or something close to it, so we can see where all that abnormal activity is coming from. And then you'll probably get another MRI looking specifically at that area if that focus exists, or possibly a PET scan. And then depending on how convincing that specific area is, more monitoring may be necessary. Something called a phase 2 or intracranial monitoring, where they'll put specific electrodes in the part of the brain or that specific area of the brain where it's focused on. Now, this is a whole lot of work, but why? Because we know that in patients who have surgical resection and have a consistent focus really do better and get to have their medications reduced. So if the goal here is seizure freedom, committing yourself to that 1 or 2 years required to get the appropriate diagnosis can be worth it if you are that right patient. So it's not just jumping to surgery, it's jumping to the right surgery, or considering the right surgical evaluation for every patient individually.
When we want to try to activate seizures in the epilepsy monitoring unit, we'll keep people up just a few hours. Take back their medications a little bit. That tends to trigger the seizure. So sleep hygiene is probably the most important thing. Yes.
Does the glycemic levels of glucose in blood affect that type of?
It's a good question. We don't know as much about that. These experiments and observations were related to the generalized epilepsies. A guy named Gibbs discovered that actually in the 1930s and 1940s. So I think sleep hygiene is the most important thing for these self-limited epilepsies. Trileptal, carbamazepine are drugs you try to avoid in general because they can be activating in some circumstances. So stick with things that are, if you were to treat that have like a broader spectrum of action. It's kind of counterintuitive because they're focal seizures, but yeah. Yes.
For the juvenile lab clinic, do you know the number one trigger? I can't figure out if it's diet or sleep or stress or if it's all of those things.
It could be all those things, and it will vary between people. But common things would be sleep, sometimes stress, probably to a lesser extent diet, but a contributor. And then when people are older with those is alcohol. Alcohol is a very, not while you're drinking, but when your system is withdrawing from it, will be like a potent time. So those are the things we really, when you think about kids going off to college and so forth. Yeah.
My daughter does number 4. We've done the full exome sequencing. It comes back negative. She's on Keppra, Topamax, Benzel. She's on CBD and a ketogenic diet, and she still has like 5 to 10 seizures a day. So we're obviously patients at Dr. Lawless's, and where he's in the process of trying to figure it out, and we're running out of hope, to figure out to control these seizures.
They're always tougher situations, when we're in this category, and particularly if we don't have a target. But
no, she's not on the full ratio yet. She's on 3 to 1.
All right.
We're building up to it.
Probably a 4, even how old is she?
2.
Oh yeah. So a 4, sometimes even a 4.25.
Okay.
We need to go to. What we want to see is at full levels of ketosis, what that does. So like in the 80 to 120 range, medium to high levels of ketosis is what we want. Yeah, in this category, so there's 2 things. One is don't give up hope, because we've been in this situation countless numbers of times. Like if I think back in the 30 years of working in there's always been like every moment there's like a group of children I've been worried about, you know. And then a year goes by, 6 months go by, whatever, and I think back and I think like, oh, I'm not worried about so-and-so any longer. So, you know, the statistics when you look going forward is, you know, people always say, if you don't respond to 2 well-chosen drugs, the chance that the third will work is 10%. But, as Ann Berg has said, if you keep playing that out, the majority of people find something. So, it's a matter of doing logical things. But 2 things I'm glad to hear that you're saying. One is you're on the diet, because by the time you get to 4 meds, it's too much. Like, you've gotta get that medication burden down, and the diet can help. So the diet can, you know, build up that reserve enough that it can help you to kind of clean up the regimen, and then you stand a much better chance of getting on top of things. Because the problem with multiple drugs is obviously if you're on multiple drugs, they're not working well. When you're on multiple drugs, it sedates the child. And when you're sedated is when seizures love to come out. So it's like a paradoxical reaction. If you're on too much medicine, you'll be chronically sedated, and that's when seizures are much more prone to come out. So our job is to use something like the diet that doesn't sedate you. It increases the brain energy levels. So get the diet working so the brain energy levels are higher, and then whittle away at the drugs is usually a good strategy. Yeah.
We're on the CBD oil for a few months now. We just got a different, a more stronger version of it, so we're hoping that works. Before the ketogenic diet, she used to have 10 to 30 a day. Now she's below 10. So something's working, we just don't know what. You know?
What's her level of ketosis now?
It's between 80 and 120. We check. We have the ketone strips, and we check it every day. So.
Yeah, you know, typically infants, I mean, I put in up to the 2 category, often need like ratios that get closer to 4 to 1 to really get the full benefit. And then consistently high ketosis is usually like what we need to really see how well it's working. How long has she been on it then?
Yeah, about 6 months.
6 months.
Okay.
Yeah.
Pretty good. Might have a little bit more opportunity to work with it.
Yeah.
Yeah.
I don't know if it's so much of a question.
Yes.
But she's my daughter. She's had seizures since 2009. We started with partial complex epilepsy. A year into it, it turned into tonic. It was the full body ones. Then we got something that everyone was telling me it's a tic, it's not seizures. We finally had a doctor diagnose us as a seizure, but it's the ones that you described that would go away by the time 16. She's going to turn 19. And it's gagging, the spitting, excessive saliva. That's all she has now. She hasn't had the convulsive ones, but these happen probably every week. We've been on so much medication, and we're at that point where we're losing hope. I don't know.
And then, when is gagging a big part of the seizure?
I have a video that I took this morning. If I could show you maybe a small portion of it.
Sure. Oh yeah.
And someone told me it was a tic, it's not seizures, it's acid reflux, it's endless things they told me.
Have you had a video EEG during it to capture one?
We have, and they said that it was minimal frontal lobe spikes. Every EEG she's had has been normal. And the epileptic spikes are minimal. Everything comes back normal. The EEGs, the MRIs. I was actually looking for you because we're out of Chicago, and you had moved a year before I got to your name.
Where do you guys live now?
In Romeoville. So we came all the way out here. When I saw your name on, I'm like, I need to talk to him.
One of the things sometimes to do, like if the EEGs have been like so-so with that kind of seizure, is maybe look into it with a MEG study.
MEG?
MEG. So seizures that are coming from a region called the insula can look like that, and they won't show up all that well on the scalp, and neither will the spikes. But there's a study called the MEG, and it's a magnetic study that does the same thing as an EEG, but with magnetic waves.
Okay.
Yeah, and that might be very helpful. So there's should be a scanner still up and running in Chicago.
At Lurie's Children?
May not be at Lurie yet. University of Chicago is running one, and Loyola had a scanner, still a big scanner, but there's definitely one in Milwaukee. Yeah. So maybe try that.
Okay, my other problem is that she's not pregnant. So I get really concerned about medication. Is it going to affect the baby? Could it?
MIG study won't be any impact on the baby. Yeah, you can do it. And it's just like a 30-minute to an hour study. It's not dangerous.
Would the keto diet work at all for these type of seizures?
Maybe not.
No.
If it's coming from the insulin, first thing would be trying to figure out where it is and see if there's any evidence for that. But that kind of manifestation might be that particular region. It's an area that's a little bit deep to the temporal lobe, so it doesn't show up on EEG.
Okay.